Hi, everyone. Thanks for joining and welcome to the latest presentation of the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. They're held the third Thursday of every month. Next slide, please. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide, please. Just a few tips and tricks to help before we get started and get going here. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions, although we will also monitor the chat to the best of our abilities. Today's webinar is being recorded, and you'll be able to access today's webinar along with any of the other webinars in the series on the National TRC YouTube channel. Next slide, please. Today's webinar is hosted by the Northeast Telehealth Resource Center, presented by myself, Reid Plimpton, and my brilliant colleague, Christina Quinlan. Next slide. Northeast Telehealth Resource Center is a dual parent organization, in part staffed by Medical Care Development, a nonprofit public health institute with offices in Maine and Maryland, and with some clinical expertise added by the University of Vermont Medical Center and the larger University of Vermont network. And like all TRCs, we are very honored and happy to be a part of the National Consortium of Telehealth Resource Centers. Next slide, please. And with that, I will be happy to turn it over to my colleague, Christina. Oh,
hi, thank you so
I have
much.
disclosures to do really quickly. Neither myself nor Netric or my colleague Christina here have any sort of financial interest or any other disclosures to highlight. I do want to give a special acknowledgement to Christina for being able to help us provide the expertise that we are today. And with that, I will turn it over to Christina.
Thank you so much. You're so kind. So thank you all for having me. This is an exciting time for me, only because I love telehealth. I know that the implementation of telehealth sort of came by storm and during this public health emergency, but this has been something that I have been wanting to do, have pushed other health centers to do, and began implementing early on, approximately 10 years ago in my own health center. So again, an exciting time, but difficult for sure. And we can certainly together all get through it. So next slide. Today, we're really going to focus on using telehealth to reduce social determinants of health. And I think part of the confusion around telehealth is, what is it? So previous to the public health emergency, telehealth was sort of the umbrella of all services provided via technology. So it was sort of the macro level of telehealth. And underneath telehealth, you would have telemedicine, telepsych, telepractice, virtual health, digital health, e-health, all of those things. But then, of course, the public health emergency is upon us, and the very definition of telehealth changed. So when I think about telehealth, I think about the umbrella that covers all telecommunicating services. But now they've changed it on us, so there's been a little confusing terminology. So telehealth versus telemed. Telemedicine has been more commonly used in the past. Telehealth is now the universal term for the current broad array of applications in this field. The problem is, during the public health emergency, telehealth now is considered a replacement of an in-person visit. So to confuse you more, I think about it this way. Now, telehealth is actually replacing an in-person visit. Other services that can be done remotely, digitally, I call telecommunication services. Next slide. Considerations for telehealth from home. When we talk about reducing social determinants of health to improve access and reduce barriers to care, we also have to have considerations for telehealth from the home. When we think about reducing social determinants of health, like patients who identify transportation as a barrier, limited mobility, etc., we also have to think about, is telehealth the best tool in the toolbox? And some of those considerations for telehealth from the home would be the digital literacy, their competency in being able to get on a Zoom session or FaceTime now, since the regulatory guidelines have sort of lessened. Supports for disability, right? Can they navigate the screen visually, or can they hear? Can they manipulate the technology so that they are getting a satisfying visit and can understand the plan essentially. And then the difficulty, of course, in interpreting services. That ease of use and access to the internet and all of those things, we've got to consider that from both ends, from the patients and the providers. And then, of course, for our providers, we have to think about provider and staff training, legal and regulatory guidelines, licensure barriers, evolving policy, and others. Seems big, and I think that it would have appeared even larger to implement, or we would have had bigger barriers had we not just busted through the door during the public health emergency and sort of took telehealth by storm, or tsunami, as some would say. Next slide, please. So telehealth to address social determinants of health. So first, I kind of want to talk a little bit about my role as a director of operations currently. So I work as a director of operations for an island community in Maine. It is about 16 miles unbridged off the coast of Rockland. You get there by ferry, which is an hour and 15 minutes. Our medical center is the hub for pretty much all services. Even when, or during the public health emergency, we have a large fishing population, and so there was a seafood relief. Ordinarily, maybe your health centers may not provide outreach, but we knew we're sort of the only shop in town. So we get up, we get on it, we download, we talk to the Department of Agriculture, Fisheries. It's what we do on the island. But because we're on the island, we have that geographical barrier of access to care. We have mini islands, and those mini islands have no ferry transportation, but they're in our catchment area. So we started using telehealth not only to address social determinants of health, but to increase access to primary care, primarily in the beginning, to those island populations that didn't have access. And then we also started very soon after to use telehealth sort of as the tool in the toolbox to address a rising substance use disorder population on our island. So we started about 10 years ago. There wasn't reimbursement other than a facility payment through Medicare because we were the originating site. But other than that, we looked at it as maybe the reimbursement wasn't there, but the value was there. We increased our quality dollars. We improved patient care. And above all, we increased access. So that was our mission early on. So again, when we decided to roll out telehealth, we decided to do it based on the needs of our community. We went back to grassroots movements, which is really what a federally qualified health center, their foundation is based on, a grassroots movement, and it's very mission driven. And I understand that if there's no money, there's no mission, but we're going to talk a little bit more about that in this slide. So where do we start? Where did we start to address social determinants of health? We used community and patient needs surveys to identify patients who would benefit from telehealth services. Number one, patients who identify transportation as a barrier to access and care. So this isn't about identifying transportation to get off an island necessarily in your health center or your service area. I mean, literally any patient who identifies transportation as a barrier to access and care, whether that be specialist care, primary care, behavioral health care, dental care. But for us particularly, these are things that we want to know because we are going to use telehealth as the tool in the toolbox to sort of address those barriers and help eliminate them and increase access. Older adults with limited mobility. So oftentimes, particularly during the public health emergency, when you have a patient that comes in with limited mobility, they're for sure, not for sure, but certainly oftentimes they have one or two people that are helping them get to their appointment, right? So which is another barrier because you have to rely on somebody else to help you. So what we thought about is that older adults with limited mobility, would they have an ease of use for telehealth? So we were able sort of to start thinking about, well, if they have to ask a loved one, a caregiver, to take them to an appointment, we would sort of use that same strategy for that loved one or caretaker to help them access care via telehealth and ease of use with the technology that we're going to use, either by Zoom, phone, whatever it may be, we could still rely on that person to help. And then, of course, patients with lack of insurance. Oftentimes what we did was we wanted to know everybody that didn't have insurance, because we were going to address it via telecommunications by doing some tele outreach. And we can talk about that in a little bit. We start with improving access to the effects of and the value of healthcare services, chronic care management among special populations, provide remote access to specialists in rural and underserved settings, provide healthy weight and physical activities counseling, and eligibility and enrollment. So we sort of started here we started with primary care. We weren't getting reimbursed. We added on other services like behavioral health, and even, believe it or not, substance use disorder in our MAT program is done primarily via telehealth. But then we started to think about, during the public health emergency, some of the other benefits that we would have in utilizing telehealth as sort of the tool in the toolbox. And we did that for chronic care management, which we know they do not have to be face-to-face encounters. Providing remote access to specialists. So if you're in a very rural area, particularly now, we went ahead and had our referral coordinators and case coordinators reach out to every specialist that we refer to and talk about how the workflow is for them to provide specialist appointments via telehealth. The patient comes to our health center. They come to our health center, and as the originating site, we utilize a special telehealth room. The patient has access to specialty care, and we're taking all of the vitals for that provider or that specialist. And then after the visit is over, we are directly involved in the plan after that visit, which limits the time it would take to do appropriate care coordination. So it's benefited us. Providing healthy weight and physical activities counseling. Another thing that is also covered right now during the public health emergency, we have a huge BMI issue and healthy weight and physical activities problem here. We want to increase that. And we are able to do that, again, via telehealth, where patients may not be as comfortable coming in. They may want to weigh themselves at home first, and then talk about what we can do and set self-management goals. And then, of course, eligibility and enrollment. So right now, we are about 95% completely using telecommunications to provide outreach for eligibility and enrollment, which includes our navigators and the marketplace and online Medicaid, submitting all of the applications and such. Next slide. So how do we get paid now, too? Well, we get paid a lot more than we did 10 years ago. And so that's why I'm excited during this time, because I'm seeing the shift. And without this public health emergency, I don't believe that we would see that shift in payment reform and reimbursement that we're seeing now. So as of December of 2019, 42 out of 50 states and DC maintain a telehealth commercial payer statute. 29 states, including DC, have a payment parity. Payment parity means they have to pay you the same amount if you provide a service via telehealth that they would if you had provided that service in person, to that patient in person. Originating sites where the patient is, right, may also bill the facility fee of the Q3014 to Medicare. And in many cases, you can also train your team, your LCSW, your RNs, your MAs, etc., to do some of this work. Most commercial payers pay for the following screenings and services. And I want to talk a little bit about that. When we talk about reducing social determinants of health, we talk about screenings, right? Developmental screenings, your expert screenings, your DAST, your audit, tobacco cessation. We're talking about things that we do in person and very seldom bill for. And then oftentimes, if you're a federally qualified health center, a hospital organization, a rural health center, you're not going to get paid for those services if you're receiving a global payment. So we had to diversify revenue during the public health emergency because, one, our numbers were tanking because when our providers were doing these telehealth visits, we weren't capturing the screenings, the experts, the DAS, the audit, the annual depression screening. And so, of course, I thought, okay, what am I going to do? Well, I'm going to take my school-based health center providers that had a reduction in services because the schools were closed, particularly my LCSWs, my RNs, and my MAs, and I was going to train them to do screenings. And then not only were they going to do screening, I was going to ensure that there was a referral to treatment, and then there would be a follow-up telehealth visit with the provider and that patient to follow up on that positive screening. I'm not sure how many of you have children out there, but I'm just going to give you an example. So I have 3 children. My oldest is 24, my youngest is 14. I can't tell you how many times I went in for a well visit. I'm handed all of those papers. I'm doing the developmental screenings, the pediatric symptoms list. I actually don't recall one time that my provider had time to review what I had filled out and discuss them with me. Most of the time, I would be going in and I wouldn't be finished. They would say, that's okay, you could do it later. So what I determined that these screenings are done best when they're carved out. And what that does for us, one, is it gives me, for me, doing this service via telehealth frees up my rooms, but it also, for my health center, and I would probably challenge others to disagree, but for my health center, we're putting more value in a screening because we're carving it out. We're spending the time to do the value of the screening appropriately. And then we're giving those results to the provider as a point of care decision-making tool before the patient is seen, and it is separately payable. And for Medicare, and you're an FQHC, you're getting paid your full rate. The other thing that I want to keep in mind is Cigna and Aetna, they run programs, particularly on developmental screenings and annual assessments. And so you're also going to beef up some of your pay for performance initiatives and your quality dollars by doing this. And I kind of listed a few, but next slide. Emotional and behavioral health screenings, kind of a big deal right now. Public health emergency, we have a lot of our patients in isolation. This is a perfect opportunity to check in on your patient and to provide them with a screening that I believe has more value, because you're particularly scheduling this appointment to provide these screenings, and then you're going to take the results, give it to the provider, and you know there's going to be a follow-up to a positive. The other thing that I challenge other health centers and organizations out there too, when we're thinking about reducing social determinants of health, how many times do you run reports on those positive screenings? And then do you follow up to see if every positive screening was addressed? I can tell you, when you start to peel back the layers, you're going to find that it's just as remiss to not do them, maybe more remiss to do them and not follow up on a positive screening. So think about diversifying your revenue. Think about the future of value-based payment. We know it's going to be tied to some of this integration of social care in the healthcare setting. So go ahead, next slide, please. So hot off the presses, right? A few other things. We got the full list of Medicare telehealth services, but we do have some new services that are included in that expansive telehealth list, and that many states have adopted what's been in the CARES Act already, and then some. So pay attention to your state, see where you are with your state plan, see what they've included in that benefit. But for now, new October 14th, we have added some cardiac rehab codes, intensive cardiac rehab and exercise services that can be done via telehealth. So there's 11 new codes. Next slide, please. Filling the critical gaps, right? So when I say I don't believe that, it's not a matter of if, it's a matter of when we start seeing our payment structure modeled after value-based medicine. Value-based medicine, I feel like everybody makes it sort of more complicated. I've been to so many webinars, they're talking about risk adjust, where are you, 3 years, you're going to get this. This is what I think in a nutshell about value-based medicine. Somebody's going to determine where we need to be. And where we are right now may not get you what you're paid right now. They're going to say you need to be here. If you're here, you're going to maintain your current reimbursement. If you're not here, it's going to decrease. And then what are you going to do to diversify revenue to get you back here? And then, of course, if you're above, you're going to get additional. My issue is going to be, are we ever going to get above, or are they going to kind of slap us with some measures that are unattainable, right? And I think over the course of 2 years, we're already seeing it with CMS. Some of their programs and initiatives are integrating social care back into healthcare, which are the things that we ordinarily don't get paid for separately. And so I start to think, okay, well, I'm going to use telehealth as the tool in the toolbox to help me get to a value-based payment reform that I'm going to be able to hit. And I say that in the simplest of terms. If I have 50% of my hypertensive patients that are out of control and I'm already seeing them 4 times a year, then what? Then what? How am I going to get the other 50% compliant when I'm already seeing them 4 times a year? So that's when I started thinking about filling critical gaps, using telecommunications, thinking about remote patient monitoring, thinking about chronic care management. And then I think about where am I going to put all of these patients if they came in more often than 4 times a year? And that's why I say, I think telehealth is going to be the answer and telecommunications is going to be the answer to get us where we need to be for value-based reform. Filling those critical gaps, provide episodic care for low acuity health conditions. So we're talking about either telephone E&M visits or telehealth visits for low acuity health conditions. Some of those triage, right? Those triage calls that you can treat that patient, you can visibly see enough. 2021, we're not going to have those exam components. It's going to be about medical decision making or time, right, to document your E&M coding. So think about that in 2021. When people right now are hesitant about telehealth, what about the physical? What about the physical? Well, when you look at the 2021 E&M code guidelines, the physical and history components are no longer a matter. It's medical decision making and it's total time. So think about episodic care for low acuity health conditions. MAT, we're doing it now. We've been doing it for a while. Patient's home is allowed to be the originating site pre-COVID. So, I mean, pre-public health emergency, I believe it was January of 2019, we could provide via telehealth services for SUD patients with a co-current mental health diagnosis. This had already been written in CMS's plan as a benefit. So that was already there. Follow up to labs. So follow up to labs when point of care decisions are easily made when labs and vitals have been completed. When I say follow up to labs, I don't think we should call a patient and say your labs are negative. We're going to go ahead and bill you a low level E&M. What we were doing is that we were getting our patients in for their labs, and then we were taking their height and weight and vitals. And then the provider was following up to the labs and had current height, weight, and vitals. We also learned, though, that when the patient was doing their labs, sometimes they would have a high blood pressure. So we had to tweak that a little because all of a sudden my white coat hypertension was increasing, but we worked out those kinks. And now one of the sort of big wins in our telehealth surveys were when we asked patients, when would you prefer telehealth over an in-person? Follow-up to labs was a big one. So that was great. And then don't forget to turn your telephone call into a telehealth visit. The way that we have it set up right now during the public health emergencies, the providers are doing the triage. So when the provider calls it, they're either going to bill a triage call, right? Brief clinical discussion with a patient, or they're going to turn it into a telehealth visit, or the patient's going to have to come in and see face-to-face. And so those are 3 things. Don't just like have your telephone E&M and kind of cut it off there. If it goes beyond that brief clinical advice, it is a telehealth visit. Document your time, the necessary components, and finally, providers are going to get reimbursed for telephone calls when they are giving clinical advice by phone. The patient did not have to physically be seen. Oftentimes, you're calling in a prescription, and the patient is okay with the plan. So that's really important. Chronic care management, especially with recent labs and vitals, your RNs can be on top of that. Your population health nurses can be calling patients. And then let's not forget, it decreases no-show rates. We actually know that now. We have enough data to feel confident about that, but there are less no-shows on telehealth visits than they are in-person visits. Next slide. And then virtual visit algorithm, knowing the difference. I always pop in this slide, even though we're talking about sort of addressing social determinants of health and decreasing social determinants of health by using telehealth as a delivery model to improve access care. I always throw this in because people always get confused in knowing the difference. It's not a slide that I'll go deep in, but it gives you a really good algorithm. I think this is one of the easiest sort of matrix to follow. And so this is just for informational purposes. I love the slide and I throw it on every one of my telehealth presentations. Next slide. Non-clinical uses. So this is sort of my favorite. We started doing some super cool things on the island. We knew that the boat was a barrier, the ferry was a barrier, but I know that you all have those same barriers and your patients have those same barriers. They may not be exactly the same. It may not be an ocean, but it could feel like an ocean. 2 miles could feel like an ocean, right? So traditional reimbursement may not always be there, but the value is. Linking medical and non-medical services can help providers meet their bottom line. We say this as we move towards value-based reform because we know it's coming. The other, it's better care. It's better care. It's better personal integrate. It's like the personal touches of patient care. It is the foundation of patient-centered medical home, and it really should be the foundation of improving overall care. So case management. So one of the issues that we had was, what were we going to do? We're going to put our patients on a boat, and it's $30 for them to get over to go see their WIC caseworker so that they can receive vouchers, right, for milk and cheese and formula. But they had already wasted a day of work and they'd already wasted $30 on the ferry. So that was tough. So what we did was we reached out to the local WIC offices. Of course, they were more accommodating because we're heading into a public health emergency, and said, hey, listen, in our telehealth room, we'll have our patients come to us. We'll take heights, weights, children, we'll do a lead test, we'll do whatever you want. We just want you to meet with our patient, your client, and we want to be able to reduce the burden of the transportation costs and the loss of income that it would take to get there and all the way back. They were fine with it. You know, there wasn't a lot of red tape, and our patients are super satisfied. We also, now when we're talking to patients about, have you signed up for WIC? No, I can never get there. I don't want to have to like worry about. Now we can sort of further promote this amazing service, right? Women's, infant, and children. We know that, you know, it's been an issue and it's a rising issue and continues to be a rising issue of healthy nutrition for women in any stage of pregnancy. So we can also promote the additional, taking advantage of that opportunity and improve social care just by offering a place where we're reducing the burden of them getting there. Parolees and probation officers. So this may not be something you guys, you know, want to do, but we don't have a problem with that. So our parolees, oftentimes, if you were going to do some research, I decided to call all the parole officers and say, hey, what's one of the major reasons that parolees get sent back, you know, to jail, where our tax dollars have to pay to house them, feed them, and such, right? And he says, missing their appointments, failing urine tox screen, failing to get to their appointment when they have a urine tox screen, etc. So I said, okay, well, we have a few out here. How can we make this work? And it's the very same thing. We'll do the urine tox screening. We can give them the results of that screening. The parolee and the parole officer can go ahead, they can meet, and then we're sort of good to go. And then we expand it more by reaching out to the Department of Health and Human Services, and we say, hey, can I get parents to meet with their caseworkers to increase the chances of reunification sooner with their children? Because again, if you dive deep and you call Department of Health and Human Services, a major part of the delay in the reunification of children is the, some would say excuse, I say barrier, of the lack of transportation and actually getting to the Department of Health and Human Services meeting for the reunification. So that's how we sort of started using telehealth, and again, telehealth as the umbrella, telecommunication services in a non-clinical use capacity to integrate social care in the healthcare setting. Outreach, our housing assistance is done this way, our eligibility assistance and our health educators, and it's going to continue post the public health emergency, because in my health center, we're having better encounters, better outreach encounters doing it virtually, because if a patient forgets their password or any of their documentation, they're in their home. We don't have to worry about a patient using our network to access their email, to reset their password, because that's one of the biggest barriers. If you go back and sort of talk to your outreach coordinators, particularly with the marketplace, like right now during this enrollment period, they forget their username and password. And then of course they're at your office, but it's resent to their email, and then, or they forget their email password. At least when they're home, I can control, or my navigators can request control We can navigate them through it. So it's not like technology or ease of use is really an issue there. But we, again, are increasing parking lot space during the enrollment period. We're decreasing patient traffic coming into our health center. And we're noticing less repeat encounters for things that are missed by providing the service at home. So I think telehealth is the best sort of tool in the toolbox for outreach. Next slide. Benefits, right? So we have the current shift to the alternate payment models led by CMS aligns incentives to the provision of social care. So currently, new CMS payment models, if you kind of look into them, they are aligning these incentives. So we're going to get reimbursed in some way for providing these services, and it's better care. Reducing social determinants of health. We know the non-clinical issues and how it affects a person clinically. Increase primary and specialty care, especially in rural settings. Increase social care activities that address health-related social risk factors and social needs. Increase continuity of care. Improve patient engagement, collaborative partnership, and a commitment to health equity. Commitment to health equity, I'm going to say that one more time because we know that this too is a problem. Next slide, please. Telehealth offers flexibility and affordability. Value-based care will require telehealth. I know it. It's a given. Telehealth helps increase healthcare value and affordability. We don't know the exact, I say it 100% increases healthcare value. And I'm going to say that telehealth is going to be the best tool in the toolbox if your patients are no-shows and only shows up via telehealth. That's a given. If the patient won't come to your office because they don't have transportation, telehealth's the best tool in the toolbox. So we're going to increase healthcare value and affordability if we continue this beyond the public health emergency. Virtual care technology saves patients time and money. I'm not sure what health centers, entity, organizations, but one of the things that came back on our own sort of homegrown telehealth service was time, convenience, and money was why they would choose it over and over again. Telehealth visits have a lower no-show rate. About 20% of Americans live in rural areas without easy access to specialty services. It improves team-based care, reduces no-show rates. I'm going to say that one again too. It's there twice. And may solve staffing shortages. So I want to talk about the staffing shortages. It is like impossible for us to recruit to the island, right? So if we got somebody who lived on the mainland, their travel time. But above all, just the resource of people in our rural population. We don't have a lot of people to pull in that has the necessary experience. And of course, we had sort of staff and leadership and a community of leaders that were like, well, how do we know what they're doing at home? And I was like, this is crazy, guys. You know, we judge value not by whether we can see somebody every day. We judge value of work by their value of work. And to me, it doesn't matter if they're remote or not. You're going to know very, very soon if a remote worker is doing poorly, but I can't tell you that if they were there in my office, they would do better. So when we had to hire an outreach patient navigator, I had already had 2 open positions at our health center for over 6 months with no applicants. When we shopped it around for telecommuting, we got 151 applicants with a ton of experience and really had to weed down, sort of vet it down to get that best applicant. I had never been in a position that I had to vet a bunch of applicants down to get the best applicant that wasn't even based on skill. They all had skill based on personality, mission-driven work, compassion, kindness, caring. Before it was like, okay, I've got a choice between 2. This is what I'm going to do. When we start to open up telecommuting for work and telework, I do think that the pool of people that we can choose from, of course, is going to be larger, which is for us was an absolute necessity. Next slide, please. COVID and the future of telehealth. So you guys know how I feel. I have no shame in that. I think it's going to be a necessity, particularly with value-based medicine and reform. I think it absolutely is the best tool in the toolbox for certain populations of people. I think it is a phenomenal answer to outreach. I think it is a no-brainer for patients that identify transportation as an issue. So what can we expect, right? After the pandemic is over, how are we going to prepare for the tsunami of patients who have delayed care and for those who may continue to delay care. How do we fix sloppy telehealth? How do we peel back the layers? These are things that we're going to think about. We're doing it now. And now that providers and patients, have gotten a taste of telehealth, will we be able to go back to our pre-existing policies, and should we? I vote no. What I know is that for the visits that we have positive sort of feedback, we are going to, in the future, continue to have telehealth as a patient preferred model of care. So we're going to start retraining. Would you like this visit via telehealth or in person? That's the way it's going to be within a visit algorithm. We're not going to do that for physical exams, and we're probably not going to do it for wellness visits. I don't want to have to worry about capturing vitals and doing, but 100% behavioral health for when it is the preferred choice. We're going to continue to do it. Outreach, we're going to continue to do it. Follow up to labs. And unless a patient is more comfortable coming in the office, we hope to have a continued 20-25% of all total visits being provided via telehealth. Next slide, please. Tips to get started. Find a champion. Think big, start small. Don't start rolling out everything at once. Like I said, target, for me, I used a community needs assessment as a target. I also pared it down and started with a certain population of people, so we knew we couldn't get to those island communities. Next, I went to patients that had a high no-show rate. It's like, hey, we can do it right from your home. And we noticed that we were starting to see more of those patients. Of course, identifying patients with transportation, and then of course the visits where it makes sense. So telehealth should be used as a model as a delivery model when it provides the same value or better than an in-person visit. So if you want to start with the better than an in-person visit, start with that and start building a sustainable model from there, because it feels good, right? We know that it's a better model. And so when you start there, it sort of all works out. Keep technology simple when possible, what fits your needs and budget, and reach out to folks who've already done this. And then of course, lead the advocacy efforts. Look towards your TRCs too, your primary care association, anyone that's going to help you lead advocacy efforts so that we can continue with payment reform. This is the time. This is the time when we're all doing it together and we have a larger voice. Next slide. Select resources, right, for COVID-19. So these are all active links, I believe. Reid can talk a little bit more. These are great. The telehealth and telemedicine toolkit is a good toolkit. Neptric has a great quick start guide. The Resource Center has our telehealth and COVID-19 toolkit, which is great. And then the telehealth coordinator e-training, that's really great too. So I know I'm saying they're all great because like these are my favorite, but there are plenty out there and Reid would be able to help you in ARIA if you have other questions on that. Next slide. Policy and reimbursement resources. This is sort of my wheelhouse. I am up to date. I focus on this and I couldn't expect that all of you would have the time to do that, but there are people like me out there. Connected Health, phenomenal. I go to them too. So again, don't be afraid to look at these resources and reach out. I mean, you'll be surprised. Send the emails, send support questions. You'll get answers. Next slide, please. Patient and provider resources. That Lifeline program, I was doing a little work on that. The Lifeline program with the FCC, they provide devices and subsidies to patients that have a barrier to technology, connectivity, or cost of having a mobile device. So that program we're probably going to start pretty soon implementing, which means that we're going to get a champion that's going to learn that program, roll it out to our patients. Next slide, please. And Reid, you want to talk about the next webinar? I think you did in the beginning, but you want to talk again about it?
I sure can. Yeah. So thank you, Christina, and thank you all for joining us. Christina, we do have a couple of questions already queued up, and hopefully,
Good.
as I sort of do this part, folks will continue to type them in. But as I did mention at the start, this presentation is a part of a sort of continuing National Telehealth Resource Center webinar series on the third Thursday of every month. That being said, we are taking December off, and the next scheduled webinar is in January 2021. It will be hosted by TTAC, the National Technology Assistance Center. Registration and further information will be available soon. Best bet is to check the National Consortium website. Next slide, please. Just another friendly reminder back from the start, when this event ends, as the webinar closes down, a survey will pop up. We would very much appreciate your input and would love if you take a second to fill that out. The link is here as well if you're viewing the recording at a later date. And next slide, please. I think we're ready to do some questions.
Sure.
Thanks, Aria. So Christina, I'll just read them for you if you're cool.
Yeah, that's perfect. I love that. You read them and then because I'm bouncing between the chat and the Q&A. And so if you just go for it now.
So the first one was, there's a lot of conventional wisdom among our providers that it is not possible to serve patients managing chronic conditions remotely during COVID-19, in part because you can't set it up that quickly. Obviously, this is worrying since those patients are some of the ones at greatest risk for COVID-19, and commenting on this overall would be great. What are your thoughts?
So my thoughts are, I would agree if you didn't have recent labs. I would agree if you didn't have recent vitals. So if I was looking at, and when we see chronic patients, right, we have chronic mental health patients, right? We have diabetes, we have hypertension, we have COPD. So I would need to understand more why. And I would want to make sure that this isn't provider driven and that this is evidence-based driven, because I actually disagree. I think the attention that we've paid to our chronic care population during this public health emergency has been far better than what we were doing before. So with the collaboration, like our population health nurse, she is making sure that we are hitting everybody. And if they need a lab, okay, if they have recent labs, I could understand why a point of care decision for chronic care patients may be difficult, but then you have them come into your drive-through lab and you have recent labs. Let's start there. If their labs are good, they'll have a follow-up in 6 months, right? So a provider can do a check-in, you have the labs. I guess I want to know what's different. On your hypertensive patients, your care coordinators could be monitoring home blood pressure, right? You can also get them in for a blood pressure check. And then the patient can be followed up with a chronic care visit. You're going to reduce the amount of traffic during the public health emergency, where we're starting again to see sort of the shift like we did back in May and April. So it would be better for me to sort of understand why they feel that way. And then I would probably have to challenge them with some of their concerns. For me, it's not a combative thing, but you have to make sure, is this a provider's opinion? Are you finding that the providers that feel this way are the providers that sort of don't like technology anyway? So that would be something that I would want to understand more.
Awesome. Thank you. There's a couple of folks sort of echoing your thoughts in the chat. I'm going to step outside of the ones that we have queued because I do see an easy one in the chat. There are not CME credits for this specific webinar, but the NCTRC is offering CME credits for our Telehealth Hack Series webinar, which I'm hoping either some of my TRC colleagues that are on the call or Aria could throw that in the chat, but you can also find by going to telehealthresourcecenter.org. So next question. In your opinion, what will be the most important effect that the E&M guideline changes for 2021 will have on coding and billing for telehealth services?
First of all, I love this new change. It simplifies it. We don't have to talk about the level of exam, the level of history, right? All it's going to be is medical decision-making and time. You're probably going to want to focus on the medical decision-making when you look at the 99214, but it's total time, guys. So not that 50% has to be spent counseling time, your total time. But if you look at the minutes, like a 30-minute visit for a 99214, that's a little bit difficulty, although that time includes that pre-visit planning piece. I just don't know how that's going to work as far as a provider remembering some of that pre-visit planning. But the medical decision-making is straightforward. It's always been a part, not the straightforward medical decision-making. But if a provider comes in and the patient has 3 problems, and you look at the medical decision-making matrix and algorithm, he doesn't have to worry about, did I hit 5 ROIs? Did I do a complete exam on 2 body areas? Did I do a limited history, a complex history, comprehensive history? It really simplifies it for the provider, and it gets back to just treating the patient. A complicated patient is going to be a higher level E&M. Well, what's complicated, right? I think you're going to get to a 99215 more than you would otherwise. 99215 was basically you're sending your patient out in an ambulance to the hospital. Not so much anymore. A 99215 based on time or complexity, you get 3 chronic conditions, you're looking at labs, you have to think about sort of contraindications and new prescribing for the patient because they're not doing well. That's going to get you to a 99215 more than we're going to send them on an ambulance. That's the only way to get there type of deal. So I think I have the ebook. I can send it. Helen Laban is on here. Reid is on here. I have an ebook from the AMA that I love and from the AAPC. It's short, it's sweet, and it's going to be easier for your provider. So I don't have any problem with any of the 2021 changes for E&M. And coders, it's going to save so much time. Auditors, you can spend more time worried about if your providers have everything in their telehealth visits than you would figuring out whether you have providers upcoding or downcoding. It's going to save a lot of time, actually.
Awesome. Thanks. All right. So we got 3 more in the queue here. And for folks that, I guess I should have said this at the start, if we do somehow not make it to the end of all these questions, feel free to either use the contact form on the National Consortium page or go to the network website and you can contact me as well. We will definitely make sure we get all these questions answered. So, Christina, often trust is required for an authentic visit, especially in the perinatal work setting. Do you have recommendations for establishing an emotional connection to clients via telehealth?
If I can't establish, or you can't establish an emotional connection via telehealth, then see them in person. I know, I'm not that girl, guys. I'm not going to tell you telehealth all the time. That is not me. If you can't establish that emotional connection for you and your patient, for me, telehealth is always going to be a choice, right? Right now, we took some of the choice away because of the public health emergency and the reduction of services, but telehealth is going to be a choice where it's beneficial to both, but it's not going to be a provider's choice, because we don't want a provider that just doesn't like telehealth because to not do telehealth. I don't think that that's necessarily fair either. We need to think about this. This is going to be a patient-driven sort of choice, but it's also going to be to reduce social barriers. So if you've got a provider who doesn't like doing telehealth and you've got a patient who can't get here, what do? Transportation's an issue. No-show rates are an issue. Money getting there is an issue. Provider doesn't like telehealth. We're going to see the patient telehealth. But no, if you can't connect emotionally, behavioral health. I've got patients that 100% prefer telehealth with their high anxiety. They don't want to come in the health center now. They think they're going to get COVID. But even before that, the anxiety of going out and going into our health center, which doesn't provide much autonomy because we're on an island where everyone knows everyone, that's been a big win. It's also been a win for our mental health population being served by our primary care providers. The feedback that I'm getting from my providers, and not just me at my health center, I serve 9 other health centers in Maine. I sit on the board of Maine Primary Care Association. I sit on the board of our ACO. What the feedback that I'm getting too from the majority of providers is that if they're carving out a visits that's specific to mental health, they're finding themselves more engaged with that patient via telehealth than they would be sitting in an exam room with a mask on.
Just checking to make sure that I hadn't missed any questions here. Thank you. I would say that sort of website manner is what we jokingly kind of call it here at Netric, is definitely a topic of hot debate. I think all of the TRCs have done a nice job of sort of thinking about some clinical considerations, clinical engagement type things via fact sheets, and I think most of them are on the National Consortium website as well. Having no clinical experience at all, so take this with a large grain of salt. I tend to add my dog to meetings that I feel like I could add a little personality to. She's taking a nap right now. I'm a little surprised we haven't seen her yet. So we do have a question that I'm gonna in the spirit of TRCs being vendor agnostic, I'm gonna shift a little bit out of sort of the platform specificity of it. But knowing that your health system and some of the health systems that we've worked with here at Netric as well have worked with a variety of platforms. Do you find that there are some aspects of telehealth encounters, whether it's scheduling or the actual video visit or anything else, that are easier to navigate for patients who may be less comfortable or less familiar with some of the online aspects of the world that we're all living in?
Is that for me?
I think I can help. I mean, I can add some in thoughts, but I was curious if you find, within your sort of health system or in your experience, if you have different areas where maybe you have more education materials for patients than others.
Yeah, I think so. Electronic education is difficult anyway. The thing that I think I'm focusing on now is really trying to work on a lending library where a patient can take that iPad home that's loaded with pre-populated, that's kind of front and center with icons and literally doing a press and learn. I want to get to that point rather than navigating patients to all these different websites, different links and things like that. These are in the early stages of that. I haven't even gotten that far really to see what is working best. We did actually start to implement a vendor. I won't name the vendor. I was super excited about it because it was a tool, a patient engagement tool. They could check in as a key at our kiosk. It would load necessary screenings. They could also access those screenings from a portal. And I was getting very excited about it, particularly with like the food insecurities questions. I would rather have them answer that like in that setting than in front of somebody. And then we would be able to know behind the scenes and sort of help those patients where maybe shame could be involved in getting handed a food insecurity screenings, right? And I have to say, I did a lot of work. We did some pre-work. We embedded sort of info path documents, and I pulled the trigger on it right before the go live. Because of the technology, I was losing the wireless connection to them, and I didn't understand why. The iPads were freezing. So I was willing to walk away from something, even though I had put sort of so much sweat equity in it. But we got reimbursed, but I'm not going to give up. I'm going to go on to that next vendor that maybe I thought was going to have a more complicated interface and start all over again with the patient engagement tools, kiosks, online surveys and such. So I guess for me, I don't know all the answers yet, but I'm not afraid to walk away from a project that I put a lot of sweat equity into. And so did my staff, but I said, guys, should we pull it? You know, we did that pre-work, we were excited. It did all of these things for us and automatic reminders and ticklers and recalls. It was great. And we're like, let's pull it because the technology wasn't we were having an issue with the hardware. So I don't know yet, but if I vet enough of them, guys, I'll have more to come back with. But I don't want to name that because somebody else might have a really good experience. But just don't be afraid to walk away.
I do think that it's important to be aware of the sort of the limitations and considerations for various platforms. That's one thing that I can add from our experience with some TAs and just our experience of looking at technology for some of the demos that we have, right? So some of the peripherals may have software that is required to be installed on the tablet or the laptop to be able to run them. And then whether or not that interacts with your video conferencing software is its own sort of dilemma. And so the IT people would probably at your health systems or at your centers would probably be happy to chat with you about this. And I personally think it'd be great. voice to have in that type of consideration, because it is a very nuanced technical world out there.
Start small, where you're comfortable, get the small wins. Small accomplishments and lead to bigger accomplishments. We didn't know how far we would go with telehealth. We did it because we had a geographical barrier. We were in the middle of the ocean. The government told us we had to treat these people somehow, some way. And we started to figure it out. And it took a little bit of time to realize that the value was better. At first, we were like, oh my gosh, how are we going to do it? It seems so large, but that was like 15 years ago. I think everybody right now has sort of been like pushed. You know, you've kind of gone over that hump. And then I think we should just think about when would it be better than an in-person visit? Let's not worry about it not being as good. We don't have to focus on those visits. See those patients in person. Let's talk about when the value is better, providing this service. And it's a model, a delivery model. And when will that delivery model be better? And kind of focus on that. And then Andrew, I sent you an email that has the ebook, also has 2 really good links. I sent this to the same sort of email to my own providers with the expectation that they would read it, because that I'll send it to them, they'll read it, they'll go, Christina, what's going on? What's happening? So they'll probably have to follow back up with you, but it's the 2 easiest resources that I found that breaks down the E&M changes. And so Andrew probably can put that in there or email all the panelists, all of the participants.
So we have time for one more question. I will give you a little bit of a hard time. I thought so. For folks that are familiar with Netric, we have a colleague named Andrew who I do like someone I like, and I thought that Christina had made a mistake, but Andrew will be forwarding that in just a second. And he's going to throw it in the chat for us as well. So the last question, I think I can help you answer it a little bit, and is just, oh, I guess it's a little bit different than what I thought it was. I'll read it out loud. We can answer it together. So I know it is an issue in rural areas with internet access, but telehealth can be phone, or currently can be phone, along with video, audio, etc. Just wanted to know if there was a survey to see where the needs are. So if we could break that apart into sort of two things, if you want to talk about like considerations where there is bad internet aspects and so on and so forth.
So we do our community needs assessment every 3 years, and then we add like mini assessments, particularly like when we were for our aging in place work and such. But you're absolutely right. Our previous community needs assessment didn't address broadband or connectivity. And so those are things that we're shuffling around now. Like, what is the best way, even beyond in reach in our own patient population, to outreach like outside, and starting to think about community broadband issues, right? How do we get, if we look at sort of community needs assessments and then we partner with other communities, right? And it's not just a health center need or an organization need, but are we identifying a community need, which of course is usually a larger funding stream for broadband, right, in those rural areas. But you're absolutely right. If a patient can't connect that way, although I will tell you, a part of the scheduling process now is they're asking the preferred method of contact. And if they say, you know, particularly for a telehealth visit, like, are you able to connect audio and video? What is your preferred method? Because right now that's been laxed. So we haven't even gathered enough data to even determine what our next steps are going to be with broadband issues. But, you know, we've got Netric here. I think we're going to find that it's going to be a community need and not necessarily a health center need. And then how do we band these small communities with these issues so that we can get improved broadband and connectivity so that we can provide these services? Otherwise, audio only works. You can triage patients. There are many audio only visits. I know that if we had somebody who was sight impaired, the video wouldn't matter. So I can't see in the future an audio only not being allowed in some regard or another, or I think the American Disabilities Act is going to protect them eventually. But audio only is better than a patient not being seen or treated at all. From there, you determine whether that interaction can be billed as an audio only telehealth visit, or if it's going to be billed as an audio telephone E&M visit.
great answer. I actually don't have that much more to add, which is great because we're running right up on time here. Thank you, Christina. And yeah, thank you
Good,
for a
you
great
got the email.
presentation. And thank you everyone who was able to join us this afternoon. Hopefully we'll see you all on a future National Telehealth Resource Center event and hear from you soon enough.
Thank you guys so much. Thank you.